go to the discussion of case discussion. Who is presenting that?
I'm presenting, sir.
Okay, go ahead.
Case scenario given to me is 65-year-old chronic smoker with COPD posted for laparoscopic cholecystectomy surgery. In history of presenting complaints, I'll ask about the complaints of pain in the right upper portion of the abdomen, whether it is associated with any nausea or vomiting, and I'll ask about the complaints of cough with expectoration for how many years. History of presenting illness. I'll ask about the complaints of pain in the right upper portion of the abdomen, its onset, whether it is sudden or insidious in onset, its duration, its intensity, whether it is radiating to some other place, or it associated with any vomiting or nausea, is it associated with any fever. Regarding complaints of cough with expectoration, its duration, whether it is continuous or intermittent, whether it is associated with any sputum or not, the color of the sputum, whether it is blood tinged or not, the quantity, seasonal variation, does it decrease with any treatment. In history of breathlessness, any history of breathlessness on exertion, history of nocturnal awakening with breathlessness or any breathlessness on lying down. I'll ask about the history of weight loss or loss of appetite or any evening rise in temperature. Any history of syncope or palpitation or chest pain or swelling of lower limbs. In past history, any history of previous hospitalization or ICU admission. Any history of any O2 support or any ventilatory support in the ICU. When was the last exacerbation and any associated comorbidities like diabetes, hypertension, tuberculosis, jaundice, epilepsy, coronary artery disease, and CVA. Any history of previous surgeries and anesthesia given to that surgery. In treatment history, whether the patient is taking any inhaler or any oral medicine, its duration and frequency. In family history, any history of similar complaints in the family. In personal history, I'll inquire about the number of years of smoking, if he's still smoking, when he did the last smoke. Any history of alcoholism, history of dietary habits, and history of bowel and bladder habits. In general examination, I look for the consciousness, orientation to time, place, and person. Whether he is well built or thin built, nourishment, and the hydration status. I'll measure the height, weight, and BMI. I look for pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. In vitals, I'll measure heart rate, BP, saturation. In airway examination, I look for the mouth opening, Mallampati grading, thyromental distance, upper lip bite test, neck movements, and TMJ mobility. In systemic examination, in abdomen, in inspection, whether the abdomen moves with respiration, any abdominal distension is there, any scar or dilated veins over the abdomen, any visible pulsation over the abdomen, any peristalsis. I'll inspect the hernial orifice and external genitalia. In palpation, I'll check for the tenderness, guarding or rigidity, tender hepatosplenomegaly. In auscultation, I'll auscultate for bowel sounds. In respiratory system, in inspection, I'll inspect whether the trachea is in midline or not, the shape of the chest, supraclavicular hollowing, infraclavicular flattening, drooping of shoulders, bilateral chest movements, whether it is increased, decreased, or normal, use of accessory muscles, and the dilated veins, any visible pulsation is there. In palpation, I'll look for the local rise in temperature, chest wall tenderness. I'll confirm the tracheal position. I'll measure the anteroposterior diameter and transverse diameter of the chest. In percussion, presence of resonant note all over the areas and presence of cardiac dullness should be there. In auscultation, I'll look for the breath sounds. Any wheeze or crepitation is present. In cardiovascular system, in inspection, I'll look for the dilated veins or scars. In palpation, I'll palpate the apex beat, whether there is any parasternal heave or palpable P2. In auscultation, I'll auscultate for the heart sounds. Summary, 65-year-old male who is a chronic smoker with a history of cough with expectoration with a symptomatic gallstone is posted for laparoscopic cholecystectomy surgery.
Now, before you go to deal with the other part of the discussion. What are the challenges you find in this case scenario? How will you classify the challenges that are included in this case scenario?
Respiratory challenges.
So first of all, the age.
Yes, sir.
Is he a geriatric patient or a younger patient? It's
Geriatric
a
patients.
geriatric patient. So you have
Yes, sir.
all the challenges of geriatric.
Yes, sir.
The second challenge is he is a
It's a
chronic
chronic
smoker.
smoker. Yes, sir.
So all the problems of smoking and the associated effects of smoking. Third is he has been diagnosed already with COPD. Okay.
Yes, sir.
So the COPD that causes changes in the long run in the respiratory tract, which are going to be problematic. And the fourth
Yes.
one is he is posted for a lap surgery. What is the challenge in lap surgery, even for a normal patient?
Sir, in laparoscopic surgery, because of CO2 insufflation, there will be increased intra-abdominal pressure.
Not only that, CO2 level is likely to rise, isn't it?
Yes, sir.
You do what is called carboperitoneum. You insufflate
Yes, sir.
carbon dioxide, which will get absorbed into the body, and temporary rise in carbon dioxide level will happen even in a normal patient. So if the patient is already a COPD patient, is he likely to have a hypercarbia or a normal carbon dioxide level?
Hypercarbia.
He may have a hypercarbia. So that will get exaggerated when the patient comes for lap surgery. So we have to adopt certain special techniques for them to maintain or to prevent a very super hypercarbic states happening. So these are the four challenges that you have to first enumerate. One is the patient is a geriatric age group patient. Second is the patient is a chronic smoker. Third is the patient who has a established COPD. Fourth is he is coming for a lap surgery where CO2 insufflation is likely to be happen. So you can always start your whether your Viva exam or in your theory exam. If this case scenario is given, you can always start like this, first identifying the problems or challenges in the case, and then go on to describe like what you have done nicely, then all the descriptions. Okay. Now you have done the examination. Now what are the types of COPD presentation
So chronic
clinically?
chronic bronchitis,
Uh,
emphysema,
emphysema.
asthma and COPD overlapping syndrome.
Asthma overlapping COPD. Primarily, early asthma will not come under COPD. Why?
It
The
is
patient
reverse.
is a pure asthmatic. Over a period of long number of years of asthma, he may become a COPD patient. But majority of the asthma patients do not develop the features of COPD. Why? So what is the difference in the definition of asthma to COPD?
Asthma is reversible.
Fantastic. That is the important thing. To a very large extent, asthma is mainly reversible with drug therapy. Whereas COPD is a progressive limitation of airflow with irreversible changes. So that the airway obstruction or the consequences of airway obstruction, they become irreversible after a period of time. Okay? The grading will be different. So how will you grade the severity of COPD?
So
I'll just
based
ask
on
some random questions because we have short of time. I'll just ask some random questions and we'll then go ahead to see how to present that. How can you assess the severity of COPD? Any indexes are you know about?
based on spirometry,
Spirometry.
we classify them as mild, moderate, severe, very severe. It's based
What is
on
that? What is there any name for that based on the
gold,
spirometry? That
gold,
FE1, FEC ratio.
yes, sir. FE1,
Called the
FEC,
gold index.
yes, sir.
Global assessment of obstructive disease, where mainly FEV1 to FEC ratio is taken to assess the severity as mild, moderate, severe, and very severe. What is the other index which is used not only with regard to FEV1 but other parameters also? Like
Predicted
body mass
FE1
index,
percentage.
yeah, that is called the BODE index, BODE, BODE index. B for Bombay, D for daddy, E for exercise. So body mass index, obstruction, that is FEV1 ratio, dyspnea, grading of dyspnea, and effort tolerance or exercise tolerance. These four parameters are taken into assess the long-term results of COPD. So you have to know about these two indices. One is BORD index and the other is the GOLD index. GOLD index merely relies on the FEV1 to FVC ratio to assess the severity, whereas the BORD index is used for long-term effect and the general involvement of all the body systems of a patient with COPD. Okay. So, how does appearance-wise, what will be the difference between a chronic bronchitis patient and a emphysematous patient? Is there any description to tell about their?
Blue bloaters and pink puffers, sir.
Fantastic, very good. So, what is the blue bloater? Why it is happening? Why they look blue?
Cyanosed, so they
They have always a high
chronic hypoxia.
amount of hypoxemia. Okay, so they have peripheral cyanosis and they usually are more obese, but they are not very dyspneic at all the time. Whereas emphysematous patients, they look pink, but they always have puffing and panting. They have dyspnea all the time. Why is that? What is the pathophysiology change that happens in these two conditions?
In chronic bronchitis, there will be dynamic hyperinflation. In
Airway passage
emphysema,
what is the first change that happens in chronic bronchitis? Which part of the lung is affected? Is it the alveoli or the conducting passages?
the distal to terminal bronchioles will get affected.
The name itself saying it is a bronchitis. So it's an inflammation of the smaller airway. So what the changes take place in the smaller airway?
Narrowing. Yes.
What are the causes of narrowing in chronic bronchitis?
Because of hypertrophy and hyperplasia of the epithelium.
Mucosal edema and secretions. Okay? These are the two important changes that happen. Super sometimes they may have smooth muscle contraction also. So the smooth muscle contraction is more in asthmatic compared to the chronic bronchitis. So the main change that happens is the mucosal edema and the secretions which form the narrowing of the tube, which makes breathing more difficult. And there will be airway air trapping will happen. And that gradually will keep on distending the alveoli, leading on to emphysema. The emphysema, what is the pathological change that takes place? Is there a destruction of the alveolar lining cells?
Alveolar walls get destroyed that will lead to permanent dilatation of the alveolar spaces.
Alveoli is what are the types of cells that form the alveoli? Histologically. You have two types of cells called pneumocyte 1 and pneumocyte 2. Okay? What is the role of pneumocyte 1 and what is the role of pneumocyte 2?
Pneumocyte 2 for surfactant production, sir.
And?
AC.
Right, surfactant production is one function. Is there any other function of pneumocyte 2?
Alveolar macrophages.
Macrophage is a separate cell by itself. Pneumocyte 2 is one which can get converted to pneumocyte 1. Pneumocyte 1 is nothing but a membrane which allows the transportation of gases. It's a much thinner cell, so that is like a membrane which allows oxygen transport across the alveoli from the atmosphere to the blood and carbon dioxide transport from the blood into the alveoli for elimination. Okay? So pneumocyte 1 is a respiratory epithelium, whereas pneumocyte 2 is a surfactant production, as well as whenever the pneumocyte 1, they keep on getting destroyed, just like your intestinal cells getting dying and falling off. The pneumocytes also, one also require replacement on and off. So the formation of pneumocyte 1 is also done by pneumocyte 2 by converting itself from pneumocyte 2 cells into pneumocyte 1 type of cells. So all these things will be affected in emphysema. So what happens? Diffusion of gases becomes difficult. So they are always the puffing stage to take up more oxygen, but they don't become hypoxemic because of this increased respiratory effort. They always maintain their oxygenation, so they look pink. They don't look diagnosed. So that is the clinical difference between chronic bronchitis, and these pink puffers are usually very lean people. They don't become put on weight or anything like that. So that is what happens to the clinical appearance. Right. Now, supposing this patient is having a moderate hypercarbia, mild hypoxemia, and he is posted for laparoscopic surgery, how will you manage this case? What will be your anesthetic management? You can talk about pre-op preparation, intra-op management, and post-op preparation and care that you have to give to these patients. That is always how you have to discuss. Whenever this question is asked in your theory exam or in your viva, you must always talk about the whole pre-operative management, which includes pre-operative risk assessment, preparation, or any pre-op treatment that you have to give to make him or optimize the patient. Intraoperatively, what are all the problems that you can anticipate, how you manage. Post-op, what are the things that you have to be prepared with. So that is how you must classify your answer for all clinical discussion cases. So any pre-op preparation you will do for this patient? What is the first instruction you should give the patient?
Quitting of
Smoking
smoking.
cessation.
Cessation of smoking.
Stop smoking. It is because here it is given chronic smoker. So chronic smokers, in spite of their debility or their COPD, they don't give up smoking at all. So as she rightly said, we must ask the patient whether he is still smoking, and if so, we must ask them to stop the smoking habit. How long does it require to stop the smoking before a patient undergoes the surgery? Or what are all the changes that happen when the patient smokes? It's another common question that examiners will ask you. What are the bad effects of smoking in the body?
Airways are reactive when patient is
Airway reactivity, okay. So when you inhale the smoke, what happens to the blood? If any other gases enter the blood?
Mm.
Carbon monoxide.
Carbon monoxide. Patient inhales carbon monoxide. Very good. So what is the problem if he keeps on inhaling carbon monoxide?
Carbon monoxide has 200 times higher affinity towards hemoglobin when compared to oxygen.
Compared to oxygen.
Oxygen.
Fantastic. Okay.
So
So
it
will it
is
be reflected in your pulse oximetry?
no,
If
sir.
the pulse oximeter probe, will it reflect the hypoxemia that because the oxygen is not carried and only carbon monoxide gets attached to the hemoglobin? Will it reflect in the pulse oximeter?
No, sir.
no sir.
Why?
It will show false high values, sir. Because
Very good. Hmm.
pulse ox only measures two wavelengths.
Hmm. So how to find out the quantity of carbon monoxide in the blood?
Co-oximeter.
We require a meter called co-oximeter. Fantastic. Very good. So that is the major problem. More than the irritable airway and secretions and the chronic smokers cough, the most important thing is patient will have more carbon monoxide level in the blood. So he will be always hypoxemic, which is not detected by the pulse oximeter. So by stopping smoking, when will the carbon monoxide leave the body? How soon it will go away, and how soon the hemoglobin will become normal?
In 4 to 6 hours.
6 hours, yes, minimum 6 hours it will start reverting. But for complete removal, it will take at least 2 to 4
And
weeks.
2 weeks.
If a chronic smoker smoking more than 10 packs per day, heavy smoker, it requires 4 to 6 weeks to become completely normalized. But at least for emergency purpose, if the patient stops smoking for 6 to 12 hours, that is good enough. The level of carbon monoxide will come down. Supposing you want to hasten the removal of carbon, can you do something?
can give hyperbaric oxygen.
Very good. You can give hyperbaric oxygen or a high flow oxygen for that matter and make the oxygen compete with the carbon monoxide and remove it. Okay, so it's a competitive uptake. So it can be achieved by increasing the inspired oxygen concentration. Fantastic. Very good. So one preparation is stopping smoking and trying to reduce the level of carbon monoxide. Any other preparation?
Chest physiotherapy.
You can give breathing exercise and chest physiotherapy so that you can clear any secretions. Especially if it's a chronic bronchitis patient, you may have constantly some lower tract respiratory secretions, which can be removed by effective physiotherapy and postural training. Very good. Do they suffer nutritionally the long run if they have COPD?
Yes.
They do have. Okay,
Yes.
they normally don't feel because of the chronic cough and dyspnea. They have always a feeling of fullness after they eat even a small quantity. So they fear that they will become dyspneic if they eat their full normal quantity and keep on gradually decreasing their intake. That will lead to nutritional deficiencies also. Okay, and if they have had any recent exacerbation, in the form of fever, increased dyspnea and all that, they may require a sputum culture and sensitivity, and an antibiotic cover should be started. Okay? So that bronchodilator therapy may be sometimes useful to patients who have an obstructive disease. So bronchodilator inhalation also should be started in these patients. So these are all the preparations that have to be done preoperatively. And what is the important cardiac function you have to assess in a chronic COPD patient? Which ventricles do not function properly? Right side or
Right
left side?
ventricle.
Right ventricular
ventricle.
strain. Very good. So patients may develop pulmonary hypertension and right ventricular strain. So what are the features of right ventricular problem or pulmonary hypertension? What history will tell you that patient with a chronic COPD of long duration has developed right heart failure or right heart problem?
Pedal edema. Elevated JVP.
Hmm. Hmm. Patient symptom wise, what will he complain of? When you complain of edema, you will not complain of JVP. You remember the mnemonic dash, dyspnea. Dyspnea will be more than what it normally is. It goes on increasing more than and not getting control with the usual lines of management. Then you have to suspect right heart problem. Okay? Then he may have syncope, sudden blackout feelings. So any COPD patient complaining of syncope, you must ask for blackout. So for a moment, for a few seconds, he says, I don't see anything, it's all blank. So that is another important thing. And if you take a blood gas, it will be severely acidotic patient. So these are the things that may have to be kept in mind. And echocardiogram, you have to measure the pulmonary pressures in all COPD patients. You have to see whether they are having pulmonary hypertension, which may suddenly land up with a pulmonary edema during induction or maintenance. So all COPD patients, in addition to the left ventricular function, you should see the right ventricular function as well as the pulmonary pressure should be checked in the echocardiographic examination. So with this pre-op preparation, then this problem of lap coli with a carboperitoneum that is going to be maintained. What are all the drugs you can safely, do you require any pre-medication for this patient? Do you want to give any antisyllagogues like glycopyrrolate?
Yes, sir.
Do you want to give any anxiolytics, the oral form?
Medazole.
Can give oral anxiolytic like alprazolam, day of night for anxiety removal, as well as you can give the acid aspiration prophylactic drugs also that can be given, usually pantoprazole or metadine. Metadine is not used nowadays. Pantoprazole can be given. So alprazolam and pantoprazole at night or in the morning of surgery before it's going to be late within 6 hours. That can be given. Okay, that will reduce the anxiety-induced COPD problems. Right. Now, once the patient is on the OT table, have you ever had a case of lap coli done? Have you been there in the theater when it is done? Kayal,
Yes, yes, sir.
you have seen. Okay.
Yes, sir.
So, can you tell me step by step how you manage a patient? Not forget about COPD. Tell me the steps of managing patient. What anesthesia you gave for lap coli?
General anesthesia with endotracheal
Endotracheal
intubation.
tube intubation. Very good.
Yes.
So, what are all the steps that you followed? Patient is on the table now. Tell me step by step how will you manage this case?
First, I'll reoxygenate the patient, sir.
Okay, first IV line should be there.
Yes, sir.
Okay?
Yes, sir.
IV line, monitors to be placed. Always first thing in the exam, if they ask you, tell us the steps of giving anesthesia. You always say that I will apply the monitors and record the basic parameters. That is the answer that you have to give in the practical examination. So what are the monitors you want to use for this case?
Saturation, ECG,
Pulse
blood
oximetry.
pressure.
Don't say saturation, say
Yes,
pulse
sir. Pulse
oximetry,
ox.
ECG, non-invasive blood pressure, VTCO2, temperature. These 5 things are considered as the basic monitors. Okay, pulse oximetry, NIBP, ECG, VTCO2, and temperature monitoring are the basic 5 parameters. Standard monitors recommended by the Association of Anesthesiologists. So, so we have applied all the monitors. We have taken the readings, and IV line is already there. So you do pre-oxygenation. So what is the risk in doing pre-oxygenation for a COPD patient compared to a normal patient? When will you avoid giving too much of oxygen? Supposing the patient's normal PO2 itself is only 80 as per the ABG, and his saturation is around 88 to 90, and he has an CO2 of 55 all the time. Can you give 100% oxygen pre-oxygenation for this patient?
No, sir, that
Ah,
patient may be CO2 dependent for respiration.
is it dependent on CO2 or is it dependent on hypoxic drive?
Hypoxic.
Ah, see, patients who have hypercarbia all the time, they are dependent on the hypoxic drive of the respiratory center for their normal respiration or for breathing. Okay. So if you abolish that hypoxia by giving too much of oxygen, then you may suddenly stop breathing because the hypoxic drive is not there to the respiratory center. You will go in for total apnea. Okay? So always a ABG before the pre-anesthetic investigation will tell you whether you can safely pre-oxygenating in the normal way with oxygen that you give for 3 minutes for all patients, or whether you have to give only oxygenation for a few minutes, few seconds, and then try to induce him as quickly as possible without pre-oxygenation. Okay? So that is one important catch question the examiners may ask you. So pre-op ABG is the one with hypercarbia and hypoxia. Avoid too much of giving oxygen as a pre-oxygenation. Otherwise, if the patient with the normal oxygen level and marginally elevated CO2 like 42 to 45 is on the other side of the normal PCO2 value, then you can safely give the oxygen. Okay, right. That is the first thing that you have to know in the starting step. Then what are the induction agents you want to use, which you consider safe?
Propofol.
Propofol can be given, very good. But what is the how is the administration of propofol to be done in this case? Can you give it
IV propofol.
rapidly, fast, or you have to give small titrated doses and see the response and then proceed? Especially if he has got a pulmonary hypertension. Is it advisable to give the propofol rapidly?
No, sir.
No. So what are the effects of rapid injection of propofol? What changes will happen?
Hypotension.
Hypotension will happen. So why hypotension with propofol is more dangerous than hypotension with hypentone? What will be the effect of hypotension due to hypentone on the heart rate? What will be the effect of hypotension with propofol on the heart rate?
Propofol will cause bradycardia
It
in
will not
hypentone.
allow tachycardia. Compensatory tachycardia will be there in hypentone, whereas compensatory tachycardia to hypotension will not happen in propofol. So that is the reason why you have to be very, very watchful and careful while administering propofol. You must give small quantums of 10 milligram, 20 milligram, wait for thing, give fluids, then check the BP and stop the injection when the eyelash reflex is gone. So the minimal dose with which you can induce the patient should be used for induction of a patient with COPD coming for general anesthesia. And that way you can avoid a sudden hypotension as well as a precipitation of pulmonary edema if the pulmonary pressures are high. Then what other, supposing you don't want to use propofol, what other agent can be safer?
Ketamine can be used, sir.
Ketamine or etomidate. Okay, so ketamine or etomidate, but what is the risk with ketamine?
It increases the
Increase in
secretion.
secretions.
Increase in secretion, very good. Then what is the effect on cardiovascular system by ketamine?
Increase in BP.
Increasing the heart rate and blood
Okay.
pressure. Okay? But it has a good bronchodilator activity.
Right.
So you can combine ketamine
With
and
propofol.
propofol in equal volume and then try to inject both so that This will counteract the effect of the propofol. The hypotensive effect of propofol will be counteracted. And what is the name of the drug when you combine this propofol and ketamine?
Ketofol.
This is called ketofol. Okay, so ketofol will be a better drug than using propofol or ketamine alone. Or the next drug of choice will be which will keep a stable cardiovascular status, which I told you in the earlier slide. Imidazole group of drug.
Etomidate.
Etomidate. Okay, etomidate is also a safe drug for this case. So these are the three induction agents you have to remember. One is propofol alone. Another is propofol and ketamine combination, ketofol. Third is etomidate. Okay, so these are the three induction agents that can be used. Yes. What about the relaxant? You said you want to intubate the patient. So which relaxant will be safe for intubation in this case?
Vicuronium.
Vicuronium, okay, stay, very good. Cardio stable. But if you want a easy reversal at the end, which drug will be easier?
Acronium.
Rocuronium is more difficult to reverse, of course, unless you have Sugammadex. A drug which is not dependent on the kidney or the liver, a relaxant.
Atracurium.
Which atracurium?
Atracurium.
This atracurium, because atracurium per se is supposed to have histamine release and it can increase bronchospasm. Okay, so cisatracurium is devoid of this problem. So either vicuronium or cisatracurium will be the drug of choice for relaxation and intubation. And during intubation, the airway can be stimulated and it can have a reactive response. So how do you avoid that reactive airway? What drugs you can inject to prevent the reflex response of stimulation of the laryngoscopy and the tracheal intubation?
Micro spray, sir. Topical
Okay.
liquid.
Topical spray or you want to give anything IV?
Loxicard or IV. IV Loxicard means
IV Tylocaine. Don't mention the trade name or commercial name, Loxicard. It is
Yes.
Tylocaine parenteral IV preparation 1 to 1.5 milligram given before induction agent, 90 seconds before giving the induction agent. That usually abolishes or diminishes the airway reflex responses to laryngoscopy and intubation. So that is the first drug you give. Wait for 90 seconds, then go for your induction, then go for your relaxant, and do a quick laryngoscopy and intubation. What about the maintenance? Once you have succeeded in your intubation, how do you maintain the anesthesia for this case? What are the inhalation agents you can use safely? Number one. Number two, what are the ventilatory parameters you will set up for ventilating this patient? That is how you should answer this question. Which anesthetic agents can be used? You said you have used you have done a case, so you must know what are the agents that you used.
Sevoflurane.
Sevoflurane in oxygen and air or oxygen and nitrous oxide?
Oxygen and air.
Air, okay. When will you avoid nitrous oxide?
Bowel surgeries.
Bowel surgery, middle ear surgery, patients with pulmonary hypertension also better to avoid. Okay, so oxygen, air, and sevoflurane. If you will have some other option, which volatile agent will be better than sevoflurane? If supposing patient has some asthmatic issues also, bronchospasms. So which volatile will cause a good bronchodilation?
Halothane.
Halogen, which is not normally used nowadays. That is also a boulder agent. It's a very good bronchodilator, but it can produce a lot of. Okay, 1 second. Thanks, guys, for the message and the patient discharge. Okay, okay. Mm-hmm. 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 அதான் 4 தான் போட்டாங்களா 4 lakhs போட்டு முடிச்சிட்டாங்க போட்டு பேஷண்ட்ஸ் ஆர் வெரி ஹாப்பி அண்ட் தேங்க்யூ ஸோ மச் நான் பேசுறேன் அப்புறம் உன்னோட கிளாஸ் எடுத்து தான் நடக்குது ம் 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 சரி சரி ம் எது வந்து ஐஐடிவா ஓகே ஓகே ஆ சரி 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 ஓகே சரி 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 ரைட் நான் பேசுறேன் கிளாஸ்ல இருக்கேன் அப்புறம் கூப்பிடுறேன் தேங்க்யூ sorry so the maintenance is with the volatile and the oxygen and air and what are the ventilatory parameters you should set to prevent hypercarbia happening? Normally, for a ventilator setting, what are the things you take into account?
We can hyperventilate the patient, increase the respiratory rate and I ratio.
So you can increase the respiratory. First of all, tidal volume, low tidal volume, increase rate, increase the IE ratio. These are the 3 things that you have to remember. So 4 to 7 ml per kg of tidal volume and respiratory rate between 20 to 24 and the IE ratio instead of 1:2, make it 1:3 or even 1:4 depending upon the respiratory time. Okay, that will make the ventilatory parameters much more safer for you. And along with the EgCO2, when the carbon dioxide get absorbed, what are the cardiovascular changes that will happen? There will be slight hypercarbia as soon as the CO2 insufflation is started, but that can be managed with the parameters that you set in the ventilator. But there is what is the cardiovascular response to hypercarbia or carbon dioxide insufflation? What will be the heart rate and blood pressure? Will it go up or will it be normal or will it be low? What did you observe in your case?
It will go up. It will go up.
It usually cause a slight hypertension and tachycardia.
Tachycardia.
So how can that be managed? Do you have to give any drugs to prevent that hypertension induced by hypercarbia? A drug which can stabilize the heart and provide some analgesia also, which is commonly used nowadays for all cases. An alpha-2 agonist. What is the drug?
Dexmedetomidine.
Dexmedetomidine. Yes. So people sometimes give dexmedetomidine as a IV injection during induction itself or during this stimulation caused by hypercarbia producing hypertension and tachycardia. Dexmedetomidine is supposed to nicely control that response, maintain normal blood pressure as well as heart rate. So we can use dexmedetomidine instead of using the regular recommended first bolus dose of 0.2 to 0.7 micrograms per kg. You can give small intermittent bolus doses of 10, 20 to 30 micrograms based on the body weight. That will take care of the hypertension and tachycardia. Right. Once the surgery is completed, during reversal, what are the precautions you have to exercise? How do you reverse normally a patient who has undergone a controlled ventilation with a muscle relaxation? What is the drug that you routinely use?
Neostigmine and glycopyrrolate.
Neostigmine glycopyrrolate combination, which is available nowadays as myopyrrolate. Okay. So what is the caution that you have to exercise if you are going to use this drug? What is the role of neostigmine in respiratory tract? What is it going to cause? How does the neostigmine act?
Cholinesterase inhibitor.
It's a cholinesterase inhibitor. So what will happen?
Increases the secretion.
Secretion. Cholinesterase inhibition will increase it. What is the
This is the
basis of
acetylcholine.
increase the quantum of acetylcholine available? So it is a competitive inhibition. When you use a muscle relaxant, it competes with the normal acetylcholine present at the neuromuscular junction and blocks the conduction of nerve stimulus on the muscle. So at the end of the surgery, when you want to reverse the effect of muscle relaxant, you make more acetylcholine available at the neuromuscular junction by inhibiting its destruction or breakdown by cholinesterase enzyme. Okay, so that is how you reverse the patient's neuromuscular blockade. But this increased acetylcholine not only happens at the neuromuscular junction, but wherever it is present, it will be increased, and that is the reason how the secretions also increase, because they stimulate the muscarinic receptors also and produce a increase in secretion. So to block that only, we add glycopyrrolate to prevent the amount of secretion that is there. So it can act on the bronchial tree and produce a bronchospasm also in patients who are reactive airway or COPD patient. So we have to use neostigmine in a very cautious titrated dose and make sure that we don't provoke a bronchospasm. So in these cases, it is better to give glycopyrrolate separately before you give neostigmine. Wait for the action of glycopyrrolate to set in, and then administer neostigmine separately so that this problem can be avoided. Okay? So that is the caution that we have to exercise during reversal and extubation. So during extubation also, you can repeat the lignocaine IV to prevent any response to airway reactivity during extubation. Post-operatively, what are the things that you should have already planned during your pre-operative assessment? Whether the patient will require any mechanical ventilatory support or not, that should have been assessed in the pre-anesthetic evaluation time itself. The patients who have chronic obstructive pulmonary disease sometimes may develop hypoventilation, inadequate muscle power during post-op, going for respiratory failure. So all these things should have been assessed with the effect. That is the reason why we assess the risk index by golden board indexes. If the case is a very severe case, you may even plan for elective ventilation post-operatively and then try to extubate them once they stabilize both hemodynamically and functionally. Okay? So this is how the whole process we discuss on COPD. I'll just show you a quick presentation on that. The slide visible?
Yes, sir.
So the definition of COPD is a chronic inflammatory process, progressive airflow limitation, and which is not reversible. That is the difference between the COPD and your asthma, bronchial asthma. So the two common types are chronic bronchitis and emphysema. And the histopathological changes that happen are loss of elasticity and recoil within the lung parenchyma, and the loss of rigidity of bronchial wall, causing collapse during expiration, increase in velocity in airflow, giving a narrowed bronchiole, increases in pressure, which also leads to collapse, active bronchospasm, and obstruction due to secretions. These are the two mechanisms by which the air passage gets narrowed, and destruction of lung parenchyma, causing enlargement of air sacs and emphysema. So, what are the risk factors? Smoking, respiratory infection, occupational exposure, genetic factors, and recently another genetic factor which is called FAM13A. Also, apart from this alpha-1 antitrypsin deficiency, this is a recent genetic factor included in that. And the emphysematous patients, they have this so-called blue bloaters and pink puffers. They have this these blue bloaters are the patients who have lost the hypercarbonic reflex, and they are the ones who are dependent on the hypoxic drive. So we have to be very careful while giving reoxygenation. These are the changes that happen in the between the normal and the chronic bronchitis patient and the emphysematic patient. And this is how the chronic bronchitis patient will look like, the blue bloater with the cyanosis and all that. And the history taking, remember this mnemonic, CCAN, S for smoking. They can ask you about number of pack years, how many packs per day, and the number of years of smoking. That is called the number of pack years. And what are all the effects on the body of smoking, especially carbon monoxide accumulation. Then the E stands for effort tolerance. What is the next that patient is able to generate? And another E is the exacerbation. For any recent ICU admission or need for mechanical ventilation. And whether the patient had any comorbidities like hypertension, heart disease, or diabetes, and active infection, nutritional status. So all these things should be included in the history examination. Signs of pulmonary hypertension, dyspnea, acidosis because of carbon dioxide retention, syncope due to aggravated hypoxemia, and heart failure and hypoxemia. These are the four things that have to be pulled out. Sputum, quantity of sputum, color, smell, culture, and microscopic. The difference between the sputum of COPD and bronchial asthma, more neutrophils will be seen in COPD patient, whereas eosinophils will be predominant in the sputum of bronchial asthma patient. And you have CD8 T lymphocytes present, whereas CD4 T lymphocytes in the bronchial asthma. You will have more macrophages in COPD and mast cells in bronchial asthma because mostly it is an allergic condition. And physical examination, general bill, the shape, the normal and paresis, breathing, whether the respiratory rate and lip pursing, cyanosis, dyspnea, abdomen, whether there is a palpable lever to find out right heart failure, accessory muscles and neck veins. And the investigations we have to do with the polycythemia is very common. Sometimes there may be anemic also. Because the increase in total count, neutrophil increase if there is infection, eosinophil increase if there is a bronchial asthma, and protein, urea, creatinine, and X-ray test for emphysematous or consolidation stages. ECG itself, you can find out right at right axis deviation, right at right ventricular hypertrophy, which is seen in R wave increase in V1, V2, and sometimes atrial fibrillation also can be present in patients with COPD. Echo, you have to mainly see the RV dimension and pulmonary pressures. And pulmonary function tests, which are classified into static and dynamic tests. Static is usually the 4 volumes and 4 capacities. And dynamic test is mainly from the vertical capacity in the FE1, FEC, etc. And this is how you do the measurement. PF tests also can be classified as bedside test and lab-based test. So this is a common instrument that can be kept in your Viva exam. Can you identify this instrument? This is called the right respirometer. Okay? And this is called the right peak flow meter. Both these things are used at the bedside. And what test is being done here? The lab-based test. This is called the vitellograph. Okay, lab-based vitellograph test, which is done in the lab to measure all the dynamic parameters. Then flow volume loops. This is a common thing that may be kept in the OSCE exam to find out. So normally you have a inspiratory and expiratory curves which are joined. So a loop is nothing but a combination of curves. So there is an inspiratory curve, expiratory curve, which both combined together in the same picture, it becomes a loop. So in patients with early airway obstruction, the expiratory loop becomes pretty convex, digged out. So this is called this is a classic picture of a excavated expiratory curve. Becomes cataclysmonic. So inspiration is normal, but expiration is obstructed. And this is a fixed airway obstruction. This is a variable extrathoracic. This is the restrictive lung disease, which is nothing but a miniature of the normal flow volume loop. So this is a picture you all have to remember, which may be kept in the exam to identify. And this is another way of taking the same thing. This is the classical way a pulmonary function test report will be given. So it will have 3 bronchodilators and 4 bronchodilators. All the demographic age, height, weight, everything, race will be given here. Then all the tests, FEC, FE1, FE1 to FEC ratio, post expiratory volume in 50 to 75 seconds are all measured before the prediction, bronchodilation. And they are all given as predicted value for the demographic details that you have given, and lower limit of normal, what actually the patient was able to achieve, and the percentage of prediction. So all these things will tell you whether the condition is normal, mild, moderate, or severe. And after bronchodilation, what is the improvement, whether it is increased or decreased or the same, all that can be easily done. So every one of you should be able to go through the pulmonary function test and assess the severity of the condition, and also which bronchodilator produces the best effort or the best response. That is also very important information that you get from that. And another information that you achieve by doing the pulmonary function test is you are able to judge whether the patient will be able to breathe on his own, maintain his gas values post-operatively, or whether he will require any supplementary oxygen, or whether he will require frank mechanical ventilation for some time. All that can be assessed by your pulmonary function test. And these are the other things that are normally asked in the examination. And Fowler's method to measure dextrose, that's called lab-based investigation. ABG is also included in part of the pulmonary function testing. And 6-minute walk test, pulse oximetry at rest and after walking, and cardiopulmonary exercise testing, which itself is a short note question in the current day examinations. So this is how the pulmonary testing is done. And these are all the methods how you do the case examination. Then after that you do the risk classification. After all the investigation, you classify the patient based on the board index, which has 4 components: BMA, obstruction as shown by FEV1 measurement, dyspnea grading, and effort tolerance according to the distance walk. So based on that, you can classify the patient into various groups. So approximately survival is also interpreted. So 2 points, patient has a 80% survival chance with a long-term prognosis. And the number of points increase, the survival chance and prognosis is quite poor. And the gold criteria is usually based only on the FE1 and FEC, and this assesses only the severity of the COPD. It doesn't take about the survival chances. So that is the difference between the board index and the gold criteria. And the predictors of post-op complications, patient-related is smoking and comorbidities and airway grading and age and albumin level and DNA. So these 6 things are, and 7 effort tolerance. They are patient related. Surgery related, surgery on the upper abdomen, general anesthesia, and duration of surgery and anesthesia more than 3 hours. They are all possible risk factors for post-op lung complications. The 3 important complications of COPD, pulmonary complications, are the mnemonic, remember, APE. A for atelectasis, P for pulmonary edema, E for exacerbation of COPD. And optimization of this patient is stop smoking, insert spirometry, treat active infection, bronchodilator and steroids if necessary, and we'll pop up for this thing. Anesthetic management, wherever possible, regional anesthesia can be given. What is the regional that can be given for lap polycystically? Any idea?
Segmental spinal.
Fantastic. Segmental spinal. It is now the in thing that is being given. Excellent. That is one of the things. Earlier they used to do under thoracic epidural also. For high risk patients with severe COPD, cases have been reported where they have given called thoracic epidural. But after the advent of segmental thoracic spinal, this has become possible for do lap poly also under regional. So the pre-med anxiolytic anti-aspiration prophylaxis, continue routine medications except ACE, NPO, bronchodilators, monitors, all routine monitors plus EPCO2, check the soda lime status. So exhausted or old soda lime may aggravate the CO2 accumulation. So for lap poly patients or any laparoscopic patient, always check the soda lime status and make sure it is fresh. And pre-oxygenation, giving 100% oxygen should be exercised with caution in patients with chronic hypercarbia who are mainly dependent on hypoxic drive. Induction agent, propofol without metabisulfate. Some propofol has this preservative which may be allergic and causing a reaction. So ketamine or a combination of these two and etomidate are all safe. And among the relaxant, preferable will be etronium, cisaltractorium, and ultimately rocuronium if you have Sugamadex available. Intubation, wherever possible, LMA should be preferred. Nowadays, they do lap poly under third generation LMA with a drainage port for the gastric contents. That also is accepted. PT intubation after sufficient suppression of reflexes with IV lignocaine, propofol, etc. Anesthetic management, maintenance with air, oxygen, and CO or halothane. Analgesics, fentanyl, methadone, dexmedetomidine, low dose ketamine. Reversal, glycoatropine, proceed neostigmine and titrated. That is glyco or atropine to be given separately and then neostigmine to be given. And another common question they ask in the examination is intraoperative bronchospasm and tight bag. So how do you manage this? Kyle.
100% oxygen and hand ventilate the patient.
What are the causes of tight bag? Will you classify that? So it
Machine
can be
causes and patient causes.
identify the cause, whether it is machine cause or patient cause. So machine cause, it can be high gas flow rates, or patient cause, it may be endobronchial intubation. Another machine cause is activation of the oxygen flush, which may be going on silently without making much noise, or a sputum plug in patient, kinking of tube or connector, bronchospasm, malfunctioning of a valve, pneumothorax, aspiration or pulmonary edema. So management of intraoperative tight bag, if it is a machine cause, disconnect the patient from the machine and do ambu bag ventilation. Once you are able to ventilate well, that means the machine is at fault. So find out the defect in the machine and change it. On the contrary, if even ventilating with ambu bag is also difficult, then it is the patient fault. So patient cause treated according to clinical condition. Aspiration by clearance of suction, 100% oxygen, steroids, antibiotics. Pneumothorax by drainage of air with ICD. Pulmonary edema with IPPV with PEEP and diuretics, head up tilt, 100% oxygen. Sputum plug suction with saline instillation. Bronchospasm, you can use these drugs. This is the mnemonic. Same chick, salbutamol, aminophyllin, magnesium sulfate, epinephrine, and chlorpheniramine, hydrocortisone, nitrotorium bromide, and ketamine. These are the drugs in their choice for treatment of bronchospasm. What questions you can expect in this RS case is anatomy of bronchial tree, physiology of control of respiration and non-respiratory function, pharmacology of bronchodilators and their mode of administration, pulmonary function test and ABG interpretation, physiotherapy in positions for drainage of secretions in various parts of the lung, smoking hazards, cardiopulmonary exercise testing, and types of cases that can be kept are COPD for incidental surgery like hernia or ortho in the lower or upper limb, COPD patient for laparoscopic surgery, either polycystectomy or hernia repair, COPD patient for lung reduction surgery or lung transplant as a final treatment, bronchial asthma patient for airway or the other incidental surgeries, suppurative lung diseases like bronchiectasis, lung abscess, emphysema, drainage, CA lung for lobectomy or pneumonectomy. So any type of these cases are possible in respiratory system. With that, I think stop there. Any doubts or any questions on that? I think we figured the time very grossly. So I don't think we have time for any more.